Perfect.
Is that okay?
Yeah.
Sorry. Next time I'll put this one on. We won't discriminate between sides. All right. Let's get the show on the road. Okay, sickle cell anemia. All right, this is a problem with hemoglobin, right? So generally hemoglobin, we've got 4 protein subunits, 2 alpha, 2 beta subunits. Each one carries a molecule of heme, very general, right? So the hemoglobin beta gene, bless you, is what is mutated for sickle cell disease, which includes all kinds of interesting little disorders there. The HBV gene is located on the short arm of chromosome 11. And for all of you that really like to memorize stuff, and my memorization buddy is not here, that is base pair. You can read that off. So, and you guys know I'm not going to ever ask you to tell me which base pairs those are on. But so overview, and this is the incidence in the United States of sickle cell disease. So we're looking at 1 in 500 people who are of African American descent, and 1 in about 1,400 of people who are Hispanic American descent. So this is a good example of ethnic variation of allelic frequency, which is exactly what it sounds like it is. You find this mutation more often in certain ethnic groups of people. So, which is no different like the Ashkenazi Jewish families that we saw earlier on and some of those things, okay? So why exactly does this even exist? Well, in some of these populations, because of the climate, there's actually a heterozygote advantage to having at least one allele mutated. And that's because the HbS, so the hemoglobin sickle, if you have one, decreases your risk of being infected with malaria. Now, I don't think they've really fully elucidated why. One of the papers I read said that possibly infected red cells sickle preferentially, and they get cleared by macrophages. So in other words, you can get the infection, it's just self-limiting because your body is able to clear it. So that's one of the theories that seems to be out there pretty prevalent. However, if you're homozygous, so if you don't have sickle cell trait, you've got the actual disease, then you wind up with this more severe malarial infection if you actually get it. And that's probably because you get a more severe anemia and backup of the cells and all that kind of stuff. But so that's possibly why this trait has been passed on. So the life expectancy currently in the U.S. for a patient with sickle cell disease is about 40 to 60 years of age. So still not great, right? I mean, we're not talking anywhere near a normal lifespan. But compared to 1973 in the U.S., it was only 14. But I know that seems like when dinosaurs roamed, but I was almost here then, so doesn't seem like it was that long ago. So this is a slide showing the decrease in mortality for patients with, or for people with sickle cell trait in Western Africa and Western Kenya. So you can see if you have the full sickle cell disease, obviously this is not a developed country, right? Mortality between 2 and 16 months is pretty high for these patients. But you actually have a decrease in mortality with the heterozygous. Because think about it, if you got malaria between ages 2 and 16 months, that's not good. But this does help. Okay, so what do the genetics look like for this disease? So this is due to a point mutation in hemoglobin beta gene, in the HBB gene. So what happens is when you get this point mutation, it substitutes a valine for a glutamine and the beta subunit of hemoglobin. So point mutation, we're talking about a single nucleotide mutation which causes an amino acid substitution. Okay? Does that always happen with a point mutation? No, because some amino acids, right, can be different. Okay, just making sure. However, this is an example of a novel property mutation because the mutation results in a new property of the produced protein. Okay, so the new hemoglobin can still carry oxygen, just things happen to it afterwards that are not good. Okay, so it does not change the hemoglobin's ability to carry oxygen. It is autosomal recessive, and if you're heterozygous, that's called sickle cell trait, which is different than sickle cell anemia. Okay, so SCD, sickle cell disease. Again, mutation does not change the ability to actually carry oxygen. Okay, but when you have the sickle hemoglobin, the HbS, what happens is after that cell deoxygenates, instead of the hemoglobin staying nice little kind of round chains, they become these long kind of rigid polymers. So they become like these strands. I'll show you a picture in a minute. And having those strands in there causes the cell, instead of being that nice donut shape, to turn into a crescent or like a sickle. And of course those sickles can't get, those sickle shaped cells can't get through the small vessels, the tiny vasculature. They're also sticky and they start clumping together. So you get this kind of vaso-occlusive disease, pain crisis, and then of course you're going to get vascular tissue damage because not only are you going to start blocking stuff, but then those tissues are going to start necrosing, then you're going to get inflammation, and it's going to be a nasty, vicious cycle. And that's me. Okay. So this is a nice picture here. You can see, okay. So you can see the normal hemoglobin, a little cross section here. And this is what happens if you have sickle cell disease. After the red cell deoxygenates, they turn to these long strands. And that's what causes the sickling. And then you can see here where it kind of clumps up and backs up, and it just looks like it would hurt. Okay, so we're gonna watch a little video. I think I told you guys how when I was a postdoc, we had this fellow that worked in our lab, and he went back and kind of took over the sickle cell program at University of Chicago. And I was looking online to try to find, some kind of neat video or anything. And I'm watching this video of this kid, and all of a sudden they show the physician, and I went, that looks like Robert. And sure enough, it is Robert. So anyway, pretty cool. He's famous. Shown in class now. All right. Now I'm determined to do this correctly this time. I don't think I ever do. Where's my...
What game am I winning at?
Operation.
When I tell someone my son has sickle cell, the first thing they say is, oh, well, what nationality? What are you? I believe some people think that sickle cell is only an African American disease. I would like people to be aware that Sickle cell is a blood disorder that can happen to all different races. When Nicholas was diagnosed with sickle cell, I didn't believe that. Nicholas's father has sickle cell trait, and I have thalassemia minor. No one ever explained to be careful. I have children. And
as a kid growing up, you don't really know what's going on. Oh, I guess I have sickle cell.
In the early years, Nicholas's hands and feet used to swell. Hand and foot syndrome. He was an infant, but we would take him to the ER. At age 5, he had his gallbladder removed and his spleen removed. He's had blood transfusions and a blood exchange. In order to go to the ER, it has to be a pain crisis or a fever. That would happen often. Back in the day when Nicholas was from birth till around 6, they knew him by his first name. The employees at the hospital, because we were there all the time.
The pain feels like somebody squeezing you, something.
Sometimes it's so severe, the medications don't help, and he is yelling at me, right now, take me right now, and we'll go to the hospital.
It's like a lifestyle, so you kind of get used to it. I'll go in, they'll ask what's wrong, and then I'll get admitted, and that's it. I'll stay for however long I need to until it goes away.
Since Nicholas has started taking hydroxyurea, he's been able to be more active.
Hydroxyurea changed my life. I can stay home for months at a time now. I'd be in the hospital all the time when I was a kid, being able to stay at home and have like a regular schedule with sports and, school and friends.
Pretty much everything is under control because of hydroxyurea and penicillin.
How are you guys doing?
I think it's very important to have a good relationship with your doctor, because if it's just like a high-buy type of thing, you don't really be getting medicine and that's it. But if it's a good relationship, I think you'll understand more about it, be there for you instead of just like a strict business type of relationship.
Transcranial Doppler.
Every year, until you're an adult, we want to do your TCD, which is a transcranial Doppler study.
The hospital that we go to in Chicago has its own sickle cell unit. The doctors at the hospital taught me everything I know about sickle cell. They explained everything very well. When Nicholas was younger, only the hematologists understood the disease. Pediatricians didn't. But now that Nicholas is older, we found a pediatrician near our home who knows what to do, what kind of sickle cell questions to ask, what kind of advice to give us, and it's very important to have a hematologist and a pediatrician working together. It's like tag team. We've got double support. In 2010, Nicholas participated in a study regarding lung function.
Participating in the studies, I think it helps the doctors figure out more about the disease and, come out with more medicine and help everybody who has it.
I feel people should participate in the study if they feel the same way that we do. We want them to know as much as they can about sickle cell. I wish they would come up with an instant cure, of course. I wish there was something that could be given and it would be gone. But he's strong. He deals with it.
I have to pull through it. It's something that's there. You can't really do anything about it. So you just gotta get through it, stay tough.
I wish he didn't have it.
I think about it all the time. If I didn't have sickle cell, like if I'm in the hospital bed in the middle of a crisis, I'll think about it and be like, I wouldn't be here right now. Everything would be fine. He's respectful, he's fun, and he's very popular amongst his friends. And he's a good brother, a good son. Managing my sickle cell without my family would have been hard because they're always there for me. So I can't really imagine what it would be like, without having their support. And, I love him. Just want him to be successful and live a normal life. I want him to get married, have children. I hope sickle cell doesn't hinder him from having a normal life like everybody else. I don't think sickle cell will stop me because it hasn't yet. I won't let it.
So, the really sad part, on top of everything else, when you have a disease that affects children, you're not only, as a clinician, going to be dealing with the patient, but you also have to manage that patient's family as well. Because, you know, when you're dealing with adults, you can tell the adult what to do and they go home and do it or whatever. But when you're dealing with a pediatric condition, as these often are, a lot of your type 1 diabetes, things like that, you not only have to manage that patient and get the patient to understand, but you have to make sure the family understands so they can take care of the patient when they get home. Because you can tell an 8-year-old boy what to do all you want, but if the family doesn't reinforce that and support that, then you're not going to have a good outcome. Okay. So, all right, so some of the forms where you can have sickle cell disease. So you can be homozygous for the SS, where you can have hemoglobin S and hemoglobin C. You can have the beta negative thalassemia. You can have beta plus thalassemia. You can have hemoglobin SD. You can have hemoglobin SC. Obviously the SS is the most frequent, and then thalassemias we're going to talk just a little bit about at the end. Because they're different. They're not obviously sickle, but they cause a similar type of issue. Okay, so again, sickle cell trait is when you're heterozygous. These patients are rarely symptomatic, but of course they're carriers. So just like the video we just watched, the dad was a carrier, the mom not knowing to have beta thalassemia, and it was a little bit of a recipe for disaster. But the homozygous, the double-strand SS, that's the sickle cell anemia, and that's the most severe form. And of course, like I said, you could inherit other forms of the hemoglobin genes. Okay, signs and symptoms. So first of all, in the United States, DC, in our territories, we require all newborns to be screened for sickle cell at birth. Okay, so that's because most of these patients will start seeing signs by 5 to 6 months of age. And the sooner that you can start preparing that, talking to the family, making sure that this infant is getting looked at, and being followed, the better they'll do. Usually, especially for infants, the first event you'll see is the dactylitis, the swelling of the hands and feet, just like the little boy said in the video. And it's bad. If you've seen pictures, they're really swollen. It looks incredibly painful. Often they'll have a bout of anemia. A lot of times they'll be very tired or fussy. And of course, if they don't have anything else going on and they haven't been diagnosed through a blood screen, well, okay, so your 5-month-old is fussy. That's probably not unusual. So, but a lot of times that goes along with the anemia. If they're breastfeeding, they may not latch on very well. They're pretty tired. And of course, they can also submit with jaundice from the red cell hemolysis. Now, one of the worst things these patients go through are pain episodes that are called crises. So patients describe this as an extremely sharp, intense pain. Typically, it's seen in regions like the lower back, legs, arms, abdomen, chest, and sometimes it's precipitated by some other event, like an illness, temperature changes, a big swing in temperature, stress, dehydration, high altitudes. So if these patients are going to take a trip to the Rockies, you probably want to counsel them about what to look for and what to think about before they go. Make sure they're going to stay hydrated, all that kind of stuff. That also means a lot of patients mentally have a hard time because they're so consumed with making sure that they don't go through these things that they start altering their lifestyles as well. Like that little boy said, he thinks about it all the time. So what are some of the complications? A lot of times these patients, especially as they get to be adults, have chronic pain. They've just had so much tissue damage by this point, especially down the bottom, like their joint pain, that they're always in some, at least low level of chronic pain. Which of course then you have to be careful of things like depression, right? Because patients who suffer chronic pain also then wind up depressed because of the chronic pain, which then also can worsen the depression. So you get into a vicious cycle. You can also have severe anemia. So we're looking at like splenic sequestration crisis. And I think if I'm not badly mistaken, a lot of times for children especially, that can be brought on by like Fitz disease, the slap cheek disease in kids. So when they're little, which, I mean, most kids get that at some point, you have to be really careful for things like this. Also, if they go into aplastic crisis, and of course you're looking for symptoms just of generalized severe anemia, right? Shortness of breath, severe fatigue, dizziness, all those things. These patients also are at high risk for infection. Because think about the clumping of these cells. One of the biggest places they're going to clump and cause damage is the spleen. Then you have liver complications. One of the worst being the intrahepatic cholestasis. The leading cause of death for these patients, though, is acute chest syndrome. A lot of times patients will present with this like a few days into a crisis. A lot of times they've had some type of infection beforehand. You know, you get a nice bout of bronchitis and these patients can quickly deteriorate. So we're talking about some pretty severe lung damage here. This is serious. This is an immediate emergency room, admit, watch this patient very closely. These patients are also at pretty high risk for stroke. Not a surprise. You're clumping off the microvessels, right? So up to 24% of patients with sickle cell anemia, so the homozygous patients, have had a stroke by age 45. And remember, not all strokes are fully debilitating, but they have had those acute infarctions that you'd be able to see on scans. And there's also something called silent brain injury, which is pretty much some of those strokes that you don't see the long-term clinical manifestations from. But especially for kids, think about it, if you're a 2-year-old with little kind of mini strokes all the time, you're probably going to have some longer lasting brain injury issues. And it may even look like developmental issues in these kids, because you're not really thinking about them having strokes. It's not like, you know, they've got the hemiparalysis, but they've had just enough to cause long-term brain injury. Retinal problems. And then of course, then you have to worry about iron overload from transfusions. So what's the biggest way to probably prevent strokes for these patients? To give them a transfusion, right? Keep some of the sickling kind of diluted out. But then if you keep giving patients transfusions over and over again, then you've got problems with potential buildup of iron. So it's a catch-22. You gotta be careful with those. And there's more. A lot of these patients develop pulmonary hypertension. Really, really horrible one would be priapism. Priapism. Can't say that. So that is an erection that doesn't go away, which can then cause some pretty bad long-term tissue damage. And for kids, you're looking at potentially delayed growth, delayed puberty, and then of course for women, there's pregnancy issues. So for women especially, you really have to counsel them on becoming pregnant, the potential issues for themselves and for the baby, of course. Okay, so how do we manage sickle cell disease in the U.S.? Well, first and foremost, you got to prevent infection. Okay, so a lot of these patients are on long-term penicillin. Some physicians, after a certain age, after like age 5 or 6, if they don't have really severe sickle cell disease, they have, thalassemia minor, something like that, they may choose to stop the penicillin. But I think a lot of patients still stay on it, and especially if they've had their spleen out, they're going to be on long-term penicillin. You're going to want to make sure they're up to date on their immunizations, because the last thing they need is to have to fight an infection and potentially go into a crisis. And just like Robert was saying in the video, for kids ages 2 to 16, you're going to do a transcranial Doppler ultrasound yearly. So of course you're looking for changes, microvascular changes in the brain. You want to make sure there's no occlusions going on. If so, you're probably going to want to give them a transfusion, right? Let's reduce the risk of stroke as much as possible. And there's going to be pain management. I mean, these patients, from children all the way through, are going to deal with some amount of pain. Either the pain of the crises, or later on as the chronic pain increases. And you're always going to watch them for anemia. All right. So what else do we do for these patients? Well, like the boy said in the video, the #1 medication to treat for this is hydroxyurea. Now the nice thing is it's oral, so we're not talking about daily injections. However, it is taken daily, and it has to be taken daily and at the prescribed dose. Taking it sporadically, off and on, or I forgot, I don't feel like it today, just going off it for a month, doesn't work at all. Kind of like the birth control pill. You take it, or you got problems. Now, the difficulty for something like this, which nobody really goes into, is especially if we're looking at children, getting a pill down them every day is not horrendous. But if they like to go into denial or anything else, like my son with his insulin or checking his sugar, then it's something that the parents have to always be on top of. So again, as a clinician, it's not only educating the patient, you got to make sure the family is going to follow through as well. Okay, so what does hydroxyurea do? Several things come to find out. One, it increases the hemoglobin F, which helps to kind of dilute out the sickle hemoglobin. It also decreases inflammation. So it's going to help some with that chronic pain. So in adults, what you wind up seeing are reduced episodes of pain crisis, which I think all these patients will be very happy to have. Reduced incidence of acute chest syndrome, which is great, because remember, this is the #1 cause of death for those patients. And improvement in their anemia. So in children, what we see is reduced vaso-occlusive crisis, which is great, because now we're also reducing the risk of stroke, right? And the hands, painful hands and feet swelling, and I can imagine having a 2-year-old with swollen hands and feet that can't run around and do stuff and is hurting, and I mean, there's no explaining that to a toddler. However, there's some risk of hydroxyurea. You can see a potential drop in the white cell count, potential drop in platelets. You know, it's not completely benign. Bless you. But I think for most patients, the risk of those side effects are greatly outweighed by the benefits. Other things, of course, are the red blood cell transfusions. We've already talked about the problems with those, with the iron overload. You know, one of the things we've seen even at the hospital, not for sickle cell, but for anything else, is we're really trying to limit blood transfusions, even in the OR. I think more and more data is coming out that a blood transfusion, you know, it's a transplant. In a lot of ways, it is like a transplant. You know, we used to just hang blood. You know, I've got a couple of cardiac surgeons who are a little bit older, and, you know, they were brought up in the residency and fellowship of patients bleeding, just hang more blood. The younger surgeons were brought up in the mentality of don't waste blood. Whatever you have to do, be as careful, meticulous, whatever, so your patient's not bleeding, because there are risks to blood transfusions. So throughout the whole health system, especially at health parks, because that's where we do cardiac surgery, we've been on a huge kick of reducing our blood transfusions. We went through a big program with the surgeons and everything. We've really come way, way down on our blood transfusions. And the Society of Thoracic Surgeons, one of the things we even have to report is any amount of units of blood that patients get. From surgery all the way through discharge. So even if you get them through surgery, but their, you know, hemoglobin is dropped and you wound up having to transfuse them, it's still a transfusion. So transfusions aren't completely benign. That's moral of that story. The only cure, oops, that should be transplant, is a hematopoietic stem cell transplant. Okay, so HSC, hematopoietic stem cells, right? Not transfusion, that should be transplant, sorry. That's the only cure right now. But you need a matching donor, right? It's bone marrow transplant, basically. It's typically only done in kids. Usually by the time patients have become adults, there's enough damage that you're not going to really see a great benefit by that point. But in kids, when you have a match and it's done correctly, the results are about an 85% disease-free survival. So that's huge. But only about 1 in 10 kids actually have a donor match. So it's still not all that common, unfortunately. Okay. Just a couple minutes on beta thalassemia. Again, it's a mutation in the hemoglobin beta chain. Something crazy, like over 250 mutations or something have been identified that cause some type of beta thalassemia. So, yeah, I mean, basically just don't mess with this gene. It's pretty sensitive. Beta thalassemia is a little bit different than sickle cell anemia, though, in that what it does is it actually reduces hemoglobin production. Okay, so you're still getting hemoglobin production with sickle cell. It's just you've substituted amino acid, and therefore you get those polymers and the sticky stuff. This is actually a reduction. So if you are hemoglobin sickle beta negative thalassemia, you don't make beta globin at all. So all you have are the alpha chains. If you have the beta plus thalassemia, you have a reduced amount of beta globin made. you make some, but not all. There is no way to predict disease severity with either of them though. Okay, so just because you have some, just having the beta plus, doesn't mean that you're gonna have less severe disease. Apparently there's other things that go into this. So there's different types. There's thalassemia major, which is also called Cooley's anemia. Assuming Dr. Cooley or Mr. Cooley had it or something. And that's the most severe form of thalassemia. And there's also thalassemia intermedia. So obviously these patients can live a somewhat normal life unless they have the severe disease, because like the kid's mom, you know, she didn't seem to really, they don't talk about her very much, and you would think if she had some really severe issues, she and her husband probably would have decided, they may have decided different response to having families. However, these patients are at risk, or at greater risk for developing blood clots. So if you're putting this patient through surgery or anything else, this is something you're going to want to know about. And basically you help these patients through transfusion. Which is this is what you have to offer them, is what you have to offer them. But we know there are potential side effects. Okay. Oh, that didn't come out. Okay. So these are some of the resources that I used for this one. All right, questions on sickle cell? Nope. All right, let's take a break. About 10 minutes, and then we'll do hemochromatosis. So I can